Welcome, everyone. My name is Haley Buckner, and I'm the Professional Relations Manager for Elevate Oral Care. Thank you for joining us this evening. Before we start, I'd like to cover a few housekeeping items. For those of you who remain online past 50 minutes, your CE certificate will be emailed within hours of the completion of this talk. Be sure to check your spam folder. You are all muted, so there is no need to worry about background noise. We will have time at the end for questions, and you can submit questions on your webinar dashboard as they will be tracked throughout the talk. We have hosted an extensive series of free live CE webinars on many prevention topics. Each of these webinars were recorded and are available with free self-instruction CE at elevateoralcare.com/elevatingcare. Bookmark this page and return often to see what's new in free CE. Also, if you have a topic that you'd like to see covered, please feel free to suggest it by sending an email to info@elevateoralcare.com or by completing the webinar survey that will be sent after the completion of the talk this evening. We enjoy looking through your suggestions and creating webinars based on your requests. Tonight, we are honored to be joined by Ms. Susan Cotten as she touches on a necessary and critical topic all clinicians need to be aware of: oral cancer screening. It's more than grasping the tongue. Susan Cotten is dentistry's oral cancer coach. She is CEO of Oral Cancer Consulting and developed the Cotten method of screening. Susan works with dental professionals who want to have more confidence when screening, reducing the risk of liability and increased early detection. Susan is the dental lead for the Alliance for HPV-Free Colorado, a 2018 Sunstar RDH Award of Distinction recipient, an RDH advisory board member with the Oral Cancer Foundation, and an instructor at the National Network of Healthcare Hygienists. She has organized countless free oral cancer screening events and volunteered with a head and neck oncology surgeon providing free screenings to the homeless. On a personal note, Susan loves walking the beaches of Hawaii, watching college football, and is a former country dance competitor. Susan, I'm going to turn it over to you.
Thank you, Haley, for having me here. Thank you, Elevate. Thank you, everybody, for joining us for this very important webinar on saving lives. Have you, as a dental professional, ever felt like this? Hurried, how am I going to get everything done? The patient came late, you're running late, production-driven procedures dictating what you're going to do in that short appointment time that you have, and you're wondering, how am I going to fit in this oral cancer screening? I've been there, and that's why I'm here sharing this information with you in this webinar. There was a time in my clinical hygiene career when I always screened, but I wasn't always confident and I wasn't always thorough. I would always grasp the tongue, hence the name of this webinar, but I didn't always palpate extraorally. And I didn't always thoroughly look at that oropharynx. It was in 2008 when I had a patient to our office. She came to us as a new patient, and she'd been previously diagnosed with HPV oropharyngeal cancer and HPV cervical cancer. And having her as my patient and seeing the devastation that this cancer did not only to her mouth and her teeth, but her entire life, I knew that I needed to go back to what I was doing right out of dental hygiene school. And that was that comprehensive visual and tactile extraoral, intraoral evaluation. Every single patient, every single time. And so I did. But what I discovered, I wasn't confident in palpation. Was I in the right location for the thyroid? So I jumped both feet first into oral cancer. And ever since, I have been on a road to excellence in oral cancer. Excellence is the quality of being outstanding or extremely good. And that's what I want to encourage you in this webinar, is to have excellence in screening, in performing this life-saving evaluation that we get to do every single patient, every single time. As dental professionals, we strive for perfection, but there is no perfection. So think excellence as we move forward in talking about oral cancer and oral cancer screening. And in that journey for excellence, it's taken me to a lot of different areas, but what I needed as a clinical dental hygienist were some systems in oral cancer, and that's where the Cotten method of screening came from. And so in the Cotten method of screening, there's 4 science-based pillars. Understanding those etiologies, especially HPV, knowing those additional risk factors for oral cancer, knowing the signs and symptoms that are associated with oral and oropharyngeal cancer. And pillar number 4 is being confident and thorough in performing that visual and tactile extraoral, intraoral evaluation. And that's where we're focusing in this webinar, is pillar number 4. So what you can look forward to in this webinar, we're going to discuss and look at the components of a comprehensive visual and tactile extraoral, intraoral evaluation. And we're going to look at what are those anatomical structures in the oropharynx, because that oropharynx is where HPV causes over 70% of cancers. And we're going to talk about tonsil grade and why that's important in screening the oropharynx. But first, let's look at why are we doing this procedure? This year alone, approximately 58,450 Americans will be diagnosed with oral or oropharyngeal cancer. And that's about 160 Americans every day and almost 7 every hour. And in 5 years, only a little more than half of those diagnosed will have survived this horrific cancer. Now, we talk about this for our patients, but right here, this is my first call to action for you as dental professionals. When was your last comprehensive oral cancer screening, that visual and tactile, extraoral, intraoral evaluation? Speaking across the country on this, I'll ask all of my attendees, and sometimes there's hundreds, and I'll ask, when was your last screening? And not very many dentists and hygienists raise their hand. We're not immune to this horrific cancer. So my first call to action is to get screened. Go back to work the next day after this webinar, get screened. Get your whole team screened. Why else are we doing this? Well, ADHA in 2020, they adopted this policy saying they support a comprehensive screening for oral cancer and oropharyngeal cancer and any abnormality for all patients to achieve earliest referral for diagnosis. And along the same lines, ADA expanded their policy on oral cancer detection to include oropharyngeal, saying that dentists should conduct a routine visual and tactile examination for oral and oropharyngeal cancer for who? All patients, and not just those previously thought to be at risk due to tobacco and alcohol. So both professional associations are on the same page. Screen for oral and oropharyngeal cancer, all patients. We're held accountable to what our professional associations say. So this is critical that we stay on top of what they're saying and perform those comprehensive screenings. So both say oral and oropharyngeal cancer. They are considered 2 separate cancers. Oral cancer is that anterior portion of the mouth. The oropharyngeal cancer is in the oropharynx. Like I said, where HPV causes the majority of those cancers. So keep in mind, two separate cancers, oral and oropharyngeal. And that's what the anatomical structures are in the oropharynx. It's that posterior base of tongue, the lingual tonsils, palatine tonsils, the soft palate, the uvula, tonsillar pillars, the back wall of the throat, and that glossotonsillar sulcus. Why else is this important? Well, in coding, we don't have a separate code that says oral cancer screening or oral cancer evaluation. But in these three exam codes, this is where this procedure lies, the comprehensive periodic exam and that periodontal evaluation. Now, previous to 2021, in the descriptors of these three codes, it read oral cancer evaluation where indicated. But where is it not indicated? We can look back at what our professional associations say, all patients. Well, thanks to a group of dental hygienists, Dental Codology Consortium, which I am privileged to be one of the directors there with a whole group of amazing dental hygienists, we were able to get this changed at the ADA Code Maintenance Committee meeting. And now in the descriptor of these three codes, it reads oral cancer evaluation, period. It is not optional. So when the dentist or the dental hygienist are submitting these three codes, you are saying that you have done an oral cancer evaluation. Why else do we care? This is critical. You worked hard for your license. And I'm not going to spend a lot of time in this webinar on this, but I encourage you. Diane Glasgow-Watterson, she wrote an excellent article, Prevention versus Prosecution, Malpractice and the Dental Hygienist, Common Causes of Liability, the Failure to Detect Oral Cancer. And while it says dental hygienist, this is for the dentists as well. These are areas where we have liability in oral cancer. And the one we're going to focus on today is we're held accountable and have liability if we fail to screen patients appropriately. And that was me at one point. And so I feel like I can really speak to this because I've been all over the map in oral cancer. I don't want you to have an increased risk of liability in oral cancer. So let's dive in to that comprehensive visual and tactile extraoral, intraoral evaluation. I recommend loops and light for extraoral and intraoral, and positioning for the extraoral evaluation. The patient should be sitting upright, not lying back. And you'll see why as we go through, especially this first video that we'll watch. So to review this and dig deep into this comprehensive screening, I'm going to use some instructional screening videos, some educational photos, and a few case presentations. Please keep in mind, this is the order that I do it in. I'm not telling you that you need to do this procedure in the order that I do. What's critical is that every structure is screened. And also keep in mind, these are instructional screening videos. They are slower than what we would normally do this procedure. So keep that in mind. This is our first video looking at the extraoral evaluation. Hi, I'm Susan Cotten. I'm a registered dental hygienist, owner of Oral Cancer Consulting, and developer of the Cotten Method, a comprehensive oral cancer office system designed to give dental professionals confidence when they are screening and reduce their liability. I believe one of the most exciting things that we get to do as dental professionals is perform this life-saving evaluation, the oral and oropharyngeal cancer evaluation. So join me as we do a review of this screening. To begin, observe the head and neck for any asymmetries or abnormalities. Examine the vermilion borders, remembering they should be well defined. Examine the skin of the head and neck for any changes in color, contour, or consistency, noting any lesions, moles, or scarring. Examine the nose closely, the hairline, the part in the hair, and the ears. Ask the patient about a history of any sunburns, any personal or family history of skin cancer. When behind the patient, ask them to bring their chin to their chest. This is an opportune time to palpate the occipital nodes and the posterior auricular nodes. Continue on to the other side. Ask the patient if they are wearing sunscreen when outside. Encourage self-skin checks at home and with a dermatologist. So let's dive into that first video. So we're not going to walk up to the patient and do that. That's instructional. We know that we're going to start evaluating and looking at that patient from the minute we go get them in the reception area. And why is it so critical that we take a look at the skin during the oral cancer screening? We're in a prime position to evaluate for any abnormalities and help that patient get referred to a dermatologist if there's anything that needs to be checked out. According to the Skin Cancer Foundation, skin cancer is the most common cancer in the United States and worldwide, and 1 in 5 Americans will develop skin cancer by the age of 70. 5 or more sunburns doubles your risk for melanoma. I don't know about you, but I've had 5 or more sunburns in multiple summers. In fact, I'm a skin cancer survivor. And more than 2 people die of skin cancer in the United States every hour. So check the skin, the hairline, the part. Are there any things that don't look quite right? What's important to remember is we are not diagnosing. We're identifying and making that referral and asking patients, have you seen a dermatologist? Has somebody checked that out? Get their phone, if they have one, take a photo of it for them, get the intraoral camera out and take a photo for your records as well and help them get referred. Here's an example of what can be discovered. So this was shared with me by dental hygienist Jessica Morgan. And this lady, she went to a new hairstylist and the hairstylist said, you know that area in your part, it doesn't look quite right. I think you should have a dermatologist take a look at that. And so she did, and she was diagnosed with melanoma. So when there's a skin cancer lesion, say the palm of my hand is the lesion, like other cancers as well, there's fingers sticking out from that lesion. And they have to remove everything to get clear margins. And it's called Mohs surgery. And so they'll go in and remove what they think needs to be removed. They'll check to see if there are any fingers sticking out and if they need to go back in. And so size is critical in this because there's the lesion, graphic photo coming up, but this is what it looked like after the Mohs surgery for them to achieve clear margins in removing that melanoma from her head. So even though something may appear very small, if you notice it, point it out, encourage them to go to the dermatologist to have it checked out. There's another photo, another graphic photo. This is the closure of that Mohs surgery and what it took to close that. So we are as dental professionals, in a prime position to look for any skin abnormalities that need referral. Let's take a look at the second video in the extraoral evaluation.
Evaluate the TMJ. Have the patient slowly open and close. Evaluate for crepitus, popping, deviation, or pain on opening and closing. Have the patient clench their teeth, and with the pads of your fingers, using moderate circular motion, palpate the preauricular lymph nodes, parotid gland, and facial muscles, comparing right and left sides. Next, palpate the submandibular and submental lymph nodes. If a lymph node is detected, document if it is hard, soft, painful or painless, movable, or fixed. Roll the tissue over the mandible to aid in further evaluation for masses or swollen lymph nodes. Remember, it is the persistent, non-painful swollen lymph nodes that may be of concern. To locate the thyroid, place your finger on the tip of the chin. Bring your finger down to the first bony structure, the top of the thyroid cartilage. The next structure is the cricoid cartilage. Below that are the first two rings of the trachea, where the isthmus of the thyroid lies. Flatten your fingers and move your hands slightly away from midline. Ask the patient to swallow, evaluating for any deviation upon swallowing. Push the thyroid to one side and palpate with the opposite hand. And repeat on the other side, feeling for any masses or nodules, and comparing the right and left sides. Have the patient place their tongue on the roof of their mouth. This aids in palpating the submandibular and sublingual glands.
Okay, so let's talk about that video, the thyroid gland. When I started screening thoroughly again, I needed mentors to help me know what I was doing so I could be confident. And I've worked with head and neck oncology surgeon and ENTs. And one thing they showed me was, they said, Susan, you're not in the right place for the thyroid. So keep in mind, everybody's anatomy is different. Some people have a longer neck, some people have a shorter neck. And just like when we go to give local anesthesia, especially the IA, we're identifying landmarks in there before we go in with that needle, because we want to be in the right spot. Same thing here with the thyroid gland. Identify where that thyroid is. Start at the tip of your chin, go to the thyroid cartilage, the cricoid cartilage. Identify where that isthmus of the thyroid is so you know you're in the right spot. That's critical. One thing I want to point out in that video as well, so I talked about palpating lymph nodes, went to the thyroid and came back up, palpating submandibular gland. Now in real life, I'm not going to do that. I'm here and I'm going to do the glands and I'm going to do the lymph nodes all at the same time. Again, instructional videos, and I wanted to make those two separate. But when we're here, we're going to do everything here as well. And evaluate that TMJ. And when we have them clench, if they have a very developed masseter muscle, what does that tell us? It tells us a lot. They're probably clenching and grinding. So while I call this the oral cancer evaluation, we've got a lot of different eyes on, and we're evaluating a lot of different things at the same time to be thorough and efficient. So remember, identify properly the location of that thyroid gland. Palpation, let's talk about palpation. So palpation is not this. And it's not doing this. Palpation is with the pads of our fingers, moderate circular motion. Just like that. And palpation is critical. This extraoral palpation, it's not negotiable, because when there is cancer in the head and neck, it's going to drain to the lymph nodes. Lymphadenopathy is a significant clinical finding, especially in adults. Can be associated with acute infection, and that's typically our painful lymph nodes. I said typically are painful lymph nodes. Lymphadenopathy is also associated with some autoimmune diseases and malignancy. That means that cancer, the head and neck, has moved on. So lymphadenopathy, whenever there's lymphadenopathy, it needs further investigation. Here is our third video for the extraoral evaluation.
Next, have the patient turn their head to one side. Rest their chin in the palm of your hand. This helps the sternocleidomastoid muscle to pop, aiding in palpation. Palpate the entire length of the sternocleidomastoid muscle, noting any masses or detectable lymph nodes. Ask the patient to lift their shoulder on the same side. This allows for easier palpation of the supraclavicular nodes. Continue on that side, palpating the anterior and posterior cervical chains. Repeat on the other side, evaluating and comparing right and left sides. While performing the visual and tactile exam, it is an opportune time to talk to patients about HPV, other risk factors, signs and symptoms, and the importance of self-exams at home in between their dental appointments. So if they notice any persistent signs or symptoms or abnormalities, they can contact you for further investigation.
Now I want to stop this video right here because this is critical. So we're palpating along that sternocleidomastoid, all those cervical chains, and then into that clavicular area, those supraclavicular nodes. And why do we want to do that? Because what drains there is this upper chest cavity. And if there's a swollen lymph node, lymphadenopathy there, we want to get them referred to a primary care or perhaps their OBGYN if they're female, because that could be an indication of some drainage, maybe from the breasts into that area. And we don't need to mention cancer. We just need to say, you know, I've noticed this persistent swollen lymph node right here. What we know now is that should be investigated further. Let's get you referred to your primary care physician so they can investigate that further. And what's critical here is when we're palpating that sternocleidomastoid muscle, what really helps us do that is to have them turn their head and then dip their chin just a little, just like in the video. And it helps that sternocleidomastoid muscle to pop. And this is especially great for somebody that has a thicker neck, but I do it on everybody. And what's critical is that we guide them, because this is what happens. Okay, turn your head towards me. And they go like that, or it's like this. So we want them to do that clean turn and then just help them dip their chin just a little bit. So you get them in that right spot so they're not leaning too far forward or too far back, all of that. So little tip there on getting that patient in the right position. And there we go, just like that. Why is it critical that we palpate along that sternocleidomastoid? Because there's a lot of lymph nodes there. Lymphadenopathy, we're checking for that. But let's look at another reason. So everything that we identify won't always be cancer. So we don't ever need to mention cancer to our patient. It's just that we've discovered something that needs further investigation by the appropriate specialist. And I want to share this case with you. Some of the best case studies I have are from attendees who've taken my course, and they reach out and say, look what I discovered after I started doing this comprehensive evaluation. And this one's shared with me by Lanny Macbeth, dental hygienist with me here in Colorado. And she was palpating along the sternocleidomastoid. And remember, when we palpate there, it doesn't start mid-neck. It starts right up here behind the ear. And that's about where Lanny was. And she identified this mass, and you can see it's wrapped around the bifurcation of the carotid artery there on the right side of that photo. So it was a mass, it was hard on palpation, it was movable, there was no pain, and the patient hadn't noticed it at all when she was cleansing, her swallowing wasn't different, but Lanny identified it. And when the dentist came in, Lanny pointed it out to the dentist. They got her referred to an ENT right away, and she was diagnosed with a benign carotid artery tumor. Yay, it was benign, but it needed to be removed. Took about 5.5 hours to remove that tumor. And the surgeon said to this patient, who found this on you? And the patient said, my dental hygienist did. And the surgeon said, don't leave that dental hygienist. She saved your life, because it wasn't a matter of if, but when you had a stroke because of this benign carotid artery tumor in that area. So keep in mind, it's not always cancer, needs to be referred. If it's not right, it's wrong. What is going on? React and get that patient referred to the appropriate specialist. So we've covered extraoral evaluation. Let's move on to the intraoral evaluation. Again, this is just the sequence that I do it in. You don't need to do it in this sequence. It's just that everything be evaluated. And what I encourage the offices that I work with, what I encourage the dentist and the dental hygienist to do, and even the dental assistant can do this, is take baseline intraoral photos of soft tissue. We usually take baseline intraoral photos of the teeth, do this of the soft tissue as well, so we know what was there and when there are changes. And we know we're going to take photos when we identify lesions and that type of thing, but get those baseline photos. So let's move on. Again, we've got 3 sections. We're going to have a couple of videos to watch, some educational photos, and some case presentations. Again, loops and light, positioning for the intraoral. So this is what I do now when I do the intraoral. So I'm standing up and the patient is sitting upright for the extraoral. But what I discovered is when I needed to get a good look at the oropharynx, when I was sitting down and the patient was lying all the way back, I wasn't in the optimal position to see that oropharynx. So we talk about positioning all the time in dentistry. Where's the best position to sit for visualization and access to this area? Think of it for this procedure as well. And this is what works for me. I stay standing and I put the patient at a 45-degree angle, like in this photo, and then I adjust their height so I'm there at the optimal position for me to see intraorally. I'm setting myself up for success, especially to evaluate that oropharynx. But here's what I discovered having the patient at this 45-degree angle. My gaggers, they didn't gag as much. And that big tongue that's difficult to move, when I'm standing, I'm able to grab a hold of that tongue and move it anywhere I want it to go. And we'll talk about that in one of the videos. So think positioning. Here's our first video for the intraoral evaluation.
Begin by examining the lips and commissures, evaluating for any cracking or variations of normal and color, contour, and consistency. Next, inspect the mandibular and maxillary labial mucosa, fully retracting the upper and lower lips. When palpating, salivary glands are usually detected and uniform in size. Also evaluate for any tethered oral tissue. Bilaterally palpate the mandibular and maxillary vestibules. Retract the cheek to fully visualize the buccal mucosa and palpate between your thumb and fingers. Common findings are linea alba and lichen planus. Compare right and left sides. Using a mouth mirror, visualize the maxillary tuberosities, hard and soft palate, retromolar trigone area, and the tissue on the lingual aspect of the mandibular arch, comparing right and left sides. Next, palpate the entire floor of the mouth, feeling for any lumps or masses and comparing right and left sides.
Okay, let's talk about that video. Fully retract so you can see everything really well. Let's talk about palpating the floor of the mouth. So often what I see is palpating bilaterally here in the front, but the floor of the mouth goes back further. So palpating is angle of mandible over to angle of mandible. When I've got that mouth mirror in there and I'm looking at those soft tissue structures, what else I'm looking at? I'm looking at the teeth, any fractured teeth, any restorative things that I want to go back and take photos of or point out to the patient, ask them questions about. And so again, I've got a lot of different eyes on. While I call this the oral cancer screening, I'm doing a lot of different things so I can be thorough and efficient. So I'm looking at the tissue as well. Is there inflammation? Is it generalized? Is it localized? I'm looking at stain, all of those things. Don't forget the palate, the hard and soft palate, to visualize and palpate that hard and soft palate. And here's a case I want to share with you again by Lanny Macbeth here in Colorado. They had a new patient to their office, and this patient had been at their previous office for about 12 years. And Lanny, upon performing that comprehensive oral cancer screening, identified this hard protuberance on the palate, just to the lingual of number 13, and it didn't look quite right. So Lanny asked the patient, were they aware of this? And the patient said, yes, I am. My other office I've been at for so long, they've been watching it for several years. It hasn't changed any. And I'm not in any pain. So, everything's good. They said if they would watch it, and if they noticed that it started to change, they'd look into it further. So Lanny, using one of the Susanisms that I teach in my long course, is what we know now. Lanny shared with the patient, well, what we know now is that any sign or symptom or abnormality that persists for 2 weeks, it deserves further investigation by the appropriate specialist. And we have the ability here in our office to do a CBCT scan. Would you be open to us doing that today? The patient declined initially, but called back the next week and said, that thing you want to do to look underneath this persistent lump on my palate? I'd like to do that. So she came back in, and this is what was identified underneath that persistent, non-changing nodule on the palate. You all can read radiographs, and you can see that large radiolucency there. This patient was diagnosed with advanced stage adenocarcinoma, and she has a very poor prognosis. Persistence is key. Any sign or symptom, persistent lesion, sore, lump, or mass that persists for 2 weeks deserves further investigation. Again, it's not always cancer, but we need to find out, why is that persisting? Here's our next video in the intraoral evaluation.
Begin examination of the tongue, having the patient stick their tongue out, moving it side to side, and then to the roof of the mouth, checking the ventral surface and for any restricted lingual frenums. Next, palpate the lateral borders and ventral and dorsal surfaces between your fingers and thumbs, noting any lumps or masses. Using a moistened 2x2, unfold it and wind it into a thin, elongated piece of gauze. Have the patient stick their tongue out and wrap the gauze around the tongue, pulling the tongue to the side and slightly up to visualize the entire lateral border, ventral surface, and back to the posterior third base of the tongue and lingual tonsillar tissue. Then palpate. Repeat on the other side and compare findings. It's important to thoroughly examine the tongue and the floor of the mouth, as these are common areas for oral cancers, as well as the posterior base of the tongue, as it's a common area for HPV oropharyngeal cancers.
So let's talk about the tongue again. So we want to document all of these other things too. So we're going to have them stick it out, move it side to side, touch it to the roof of their mouth. Is there symmetry in that movement? If not, why not? Further investigation. And we also want to note things like geographic tongue. Is it coated, fissured? Is it scalloped? And if you're doing any myofunctional assessments or any airway assessments, we can do this at the same time. We're looking at the same structures, not just the tongue, but everything else in the mouth, the head and neck. So again, being thorough and efficient in all of the assessments that we want to do. So looking at that tongue, so those top two photos, there's some ways working with offices. I see that the tongue is deflected. but you can't see the entire tongue. So what I discovered worked for me, especially those difficult tongues, is I'm standing up, the patient's 45-degree angle, and I moisten that gauze. I don't know about you, but I can't stand dry gauze on my tongue, so I always moisten it. But then when I wrap it in that elongated piece, I wrap it around the tongue, and I grab the tongue and the gauze, and I can make even those difficult tongues go wherever I want them to go. So I can visualize that whole lateral border, the ventral surface, and then palpate. So again, set yourself up for success so you can be thorough and efficient in this life-saving evaluation. So our next section in the intraoral is evaluating the oropharynx. Again, it's that posterior base of tongue, lingual tonsils, palatine tonsils, soft palate, uvula, tonsillar pillars, back wall of the throat, and that glossotonsillar sulcus. And what's the glossotonsillar sulcus? So you've got the palatine tonsils here. Here's the uvula, and here's posterior base of tongue. It's that sulcular area right here towards the midline. So you want to get a good look into that glossotonsillar sulcus area. And what I've discovered for me, the best way is, again, at having this patient at the 45-degree angle, and I'm standing up, and I ask them to take a deep breath in and say ah, ah, and doing those at the same time really helps to open up that oropharynx. And when I do that, I've got my mouth mirror, and I am ready to depress as far back on that tongue as I can when they say ah, and I'm intentional, and I'm ready to look at that entire oropharynx, all of those structures. We don't want to depress on the anterior portion of the tongue because that just lifts up that back portion of the tongue. And then get a good look at all of those structures. Let's take a look at tonsil grading. That's critical in this evaluation because it's one area that HPV presents is in those palatine tonsils. Now, when I was in hygiene school, I graduated in 1994. Our evaluation was, do they have those palatine tonsils or do they not? We didn't know about HPV then. But knowing what we know about HPV, we want to evaluate and document tonsil grading. Tonsils should be symmetrical in size and color. If they're not, why not? Again, it doesn't always mean it's cancer, but we want to document those and take a photo of this. Have this in your template and document what each tonsil is, the size, and are they symmetrical in color. But also, if you're doing any airway assessments, you're going to be looking at tonsil grading as well, because we know when somebody's, what we know now is when somebody's a mouth breather, that can affect the size of their tonsils. So again, doing a lot of different assessments at the same time, but document tonsil grading. So we've gone through that visual and tactile, extraoral, intraoral evaluation. But what we know now, there are signs and symptoms associated with oropharyngeal cancer, and other head and neck conditions that we need to know, be aware of, and ask our patients about. Because sometimes these signs and symptoms will be present before an oral cancer lesion is ever identified in the oral cavity or in the oropharynx. Let's take a look at these. Persistent pain anywhere in the head and neck. And when I say persistent, remember persistence, 2 weeks and longer. If it's persistent for 2 weeks, deserves further investigation. So persistent pain, a mass or a lump anywhere, extraorally, intraorally. Difficulty swallowing or chewing. Persistent red or white patch, sores, lesions, ulcerations. A persistent change in voice, hoarseness, persistent cough, persistent sore throat, numbness, fatigue, persistent ear or jaw pain, usually one-sided, unexplained weight loss, the sensation of something caught in the throat and it won't go down, a persistent lesion, again, a sore that doesn't heal. Remember these, take a photo of these. These are things we need to be asking our patients about, and are they persistent? Now, some of these, you're saying, yeah, but some of these we get when we're sick, right? But it's those persistent things when we're not sick. I had a few of these persistent things a few years ago. My swallowing was a little different. I had a persistent swollen lymph node, a little bit of ear pain, and I had a low-grade sore throat. So I went to the ENT, he did a thorough workup on me, and I was diagnosed with laryngopharyngeal reflux. So not cancer, but a condition that needs to be watched and needed some medication. So again, it's not always cancer. If these exist with patients, just what we know now is any of these persistent signs and symptoms, they need to be investigated further. So we're going to help you get to the appropriate specialist. Use your ENTs. So when we talk about difficulty swallowing, the sensation of something caught in the throat, it won't go down, those are critical for oral cancer and especially oropharyngeal cancer, because when there is a tumor in that oropharynx, it interrupts oftentimes swallowing, and it feels like something is caught in the throat and it won't go down because there's a tumor. But cancer in there, in this whole area, also affects all of those other signs and symptoms that we talked about. Tumors can be pressing on nerve and blood supply, causing someone to have that persistent cough. So keep in mind those signs and symptoms. They're a critical part of the screening process. So those persistent signs and symptoms, this is Caitlin. Caitlin had a persistent lesion on the lateral border of her tongue, and she was 19 years old, headed off to her first year of college, but it was dismissed because she wasn't considered high risk. By the time Caitlin was diagnosed, she was diagnosed with stage 3 squamous cell carcinoma lateral border of her tongue. We are seeing an increase in tongue cancers of the mobile tongue in the younger population. A little bit more in females than males, but we're seeing it in males as well. So risk has changed. It's not just tobacco and alcohol. We know HPV, we know beetle quid, but those with no known risk factors, remember, we're seeing an increase on the mobile tongue. So what age do you start screening in your office? I encourage from the very first visit to their very last visit. And we're not going to tell kids like we do adults that we're doing an oral cancer screening. My friend Amanda Hill, she says, I tell them I'm feeling for marbles under their chin. We're going to make it fun, just like we do everything else. 6-year-old Morris Ann Henson, she had lost ENF, and there was a pea-sized knot right there, and the dentist was right on it, recognized that it wasn't quite right, referred Morris Ann. Morris Ann was diagnosed with squamous cell carcinoma of the hard palate at age 6. Is this rare? Of course it's rare, but kids do get cancer. So screening kids, critical. And then they know that that's part of their dental appointment when they go in. As they get older, they'll know to expect that. Remember, if it's not right, it's wrong. React and refer. any persistent lesion, sign, or symptom of 2 weeks. It doesn't always mean it's cancer. It could be another condition that needs some treatment. And nobody has biopsy eyes. Oh, well, watch that lesion. Are we going to watch it until, oh, now it looks like cancer? We'll refer you. We need to be more proactive on these persistent lesions. So when you're feeling like this, how am I going to get everything done? Make the time for that comprehensive visual and tactile extraoral, intraoral evaluation. Your patient will not die from stain that's left on the distal buccal of number 15. They could if this comprehensive screening isn't done. And if you don't have the time, then it's time for an important conversation with the dentist and the office manager. Advocate for yourself and for your patient. So my first call to action to you was to get yourself screened. Have a team meeting. Next, be confident in this comprehensive screening. When we're confident, we can be efficient and thorough. Think back to dental and dental hygiene school when you were learning all of these different procedures. For myself as a hygienist, I always wondered, will I ever be able to do a comprehensive periodontal evaluation, documentation, and get it right? Well, we do, we get there. Why? Because we do it over and over and over. Same with this. If you're not doing that extraoral evaluation, start somewhere and just keep doing it and get confident. Get the providers, the dentist and the hygienist, calibrated on this evaluation in your office. So everybody's screening all of the structures. Again, not in the same order, but everybody is doing it. Schedule a team meeting. We have team meetings on a lot of different things. Have you had a team meeting on oral cancer and screening? Get everybody on the same page so everybody knows about the signs and symptoms. Screen everybody on your team. So you've done all that for your patient. You've identified something and they've been diagnosed with oral or oropharyngeal cancer. You now become a critical member of their oncology team. They need you, dentist and dental hygienist, so they have the best products that they can have for their severe xerostomia that they'll experience. All of these different things. Make sure that you've got in your toolkit in your office a lot of different things that you can offer to them, because as they go through treatment, they'll need different things. What are some gels that they can use at home to either put in a tray or put on with their finger? Dry mouth sprays so that they can carry those around. They're going to have extreme xerostomia. They'll come into you for some pre-treatment before they start their cancer treatment. What are some things that you can do? Maybe some SDF, things like that for them. Have those in your toolkit to help these patients. Reach out to their oncology team and let them know that you're a part of their team as well. They need you. Thank you for joining us for this webinar. In this QR code here, that'll take you to a printout of all of the structures that we talked about in the extraoral, intraoral evaluation. It'll have tonsil grade on there. It'll have a few other things. And then it'll have some of those pertinent signs and symptoms, those questions that you need to ask. And you can use that as a template, all of it or parts of it, whatever you would like. to have in your documentation for your records to make sure that you're documenting well that you did this comprehensive screening. So thank you again, and thank you Elevate and Haley for having me here.
Thank you, Susan, for the great information that you provided us with this evening. We did just have a couple of questions come through. I'm going to start off with the first question here that I thought was really great, and it says, what do I do or say when I identify a lesion or a sign or symptom and I feel that the patient may need a referral to an oral surgeon or an ENT, but the dentist says, oh, it doesn't look like anything, we will watch it? What would you suggest for those situations, Susan?
Oh, thanks, Haley. I get that question every time I present to a group of dental hygienists. And I want you guys to write this down. Write down, I feel, I think, I want. We don't want to have this conversation in front of the patient, but do it afterwards. Have a conversation with the dentist and say, I'm feeling concerned, or whatever your feeling is, I'm feeling frustrated. Just put in your feeling, but I would say I'm feeling concerned. And I think it's because, so that's, I feel, I think. I'm feeling concerned. I think it's because this patient has this persistent lesion and it's not going away. And what we know now is that any lesion, sign or symptom that persists for 2 weeks deserves further investigation by the appropriate specialist. And Dr. So-and-so, I would love for us to get on the same page, and I would love for you to listen to me when I have a concern about a persistent sign or symptom, and I'm concerned about our liability. So if you're open to us having this patient back to check this lesion again, or even just calling them and referring them to the appropriate specialist, I would love for us to be on the same page and be able to do that. So have that conversation with the dentist. I feel, I think, I want. And when we use that structure, it's not, we're not saying, you know, you're not listening to me. We're not approaching it that way. And I've used that before. I learned that in a workshop on emotional intelligence and difficult conversations to use with the doctors that I worked with, and it works. So have that conversation with them, get on the same page. And if they're not open to that, then that's another difficult conversation to have with the dentist. But as hygienists, we're in there with our patients for a long time, and you know when something needs to be referred. So use that structure. I feel, I think, I want, and have that conversation with your dentist.
Thank you, Susan. I think that's great advice and really helps make that conversation a little bit easier. And we are over the time here, but there were just a couple of other great questions here. So if anybody wants to hang on and listen to some of Susan's quick responses here with some of these other ones, I'll just ask a couple of more here. One great question came in and asked if there was any tips for acquiring a good intraoral photo of the oropharynx.
Have somebody assist you in taking that photo of the oropharynx, because that one is difficult to do on your own. To be able, if you're standing and you've got that patient at that 45-degree angle, that helps. But to be able to depress and hold that intraoral camera at the same time to get in there far enough to get that good photo of the oropharynx, it is difficult. I always have somebody help me take that photo of that oropharynx.
That's great advice. Thank you. And another question came in, a couple of questions. You know, I know you mentioned that you are kind of focusing on one of the pillar here, and I know you also provide this course at much greater lengths. Where can people go to find some additional information and to dive a little deeper into this really important topic?
Yeah, great question. So at National Network of Healthcare Hygienists, They have my entire Cotten Method course that covers the etiologies, dives into HPV, additional risk factors, and goes deeper into the signs and symptoms, and covers this, the videos with the intraoral, extraoral evaluation. National Network of Healthcare Hygienists, on their website, you can access the entire Cotten Method course there.
Perfect, thank you. And I just put that in the chat box for everybody as well, so you can see her entire course there and find some additional resources and information. And 2 more questions here. Do you recommend switching gloves between the extraoral and the intraoral exam?
Yes, I do. Change your gloves. After the extraoral, change your gloves, wash your hands, put on a new set of gloves.
Perfect. And then what are your thoughts on oral cancer screening devices that are used in dental practices like Veloscope and I think it says oral lid here?
Yeah, there's Veloscope, Oral ID, there's the BioScreen. You know, those are good adjuncts. They are just that. They're an adjunct to this comprehensive hands-on screening. Critical is that we have good training on how to use those and what we're looking for. And so if your office implements those, or you have one and you don't feel confident in using those, get trained on those. Personally, I think the wrong reason to use those is purely for production. Oh, here, hygienist, you know, we can charge this amount and add this amount of production per patient. I think that's the wrong reason. I know lives that have been saved using these adjunct screening devices because they do show us beyond what we can see with our naked eye. But having get trained on them well and be confident in using those.
Perfect. Awesome. Well, thank you again, Susan, so much for your wonderful presentation this evening. Your passion and just knowledge of this subject is really evident. So thank you for sharing all your wisdom with us this evening. And thank you so much to our attendees for joining us and spending your Tuesday evening with us as well. So to our guests, your CE certificate will be emailed automatically within an hour or 2, so make sure you check your spam folder. And I know there were just a couple comments that came through about the videos having a glitch. This will be recorded, like all of our free CE courses are recorded and uploaded onto our elevateoralcare.com/elevatingcare webs page, so you can view this again as many times as you'd like to be able to get the information. And then be sure to follow us on Facebook and Instagram for links to new free CE events. We will have another event coming up in just a few short weeks, so be on the lookout for registration. And again, as I said, you can access all of our archived webinars at elevateoralcare.com/elevatingcare, including Susan's webinar, which will be up in just a few short weeks. And feel free to share that link with your staff and colleagues. And then finally, on our Elevate Oral Care website, you will find buttons to request an informative CE eligible staff meeting for your office. Education on the latest evidence in oral health prevention is what we do, and we would be honored to meet with you and your team to help you best serve your patients. So thank you all. Have a wonderful rest of your week, and we hope to see you on our next Elevating Care webinar. Thanks, Susan.
Thank you, Haley.